we try to start? Someone can hear me?
Yes, Professor, we can all hear you.
Okay. Just a moment, because I have a message from someone. Just to verify if. Okay. Okay. I'll try to start our lesson today, and I hope everybody are enjoyed. And everything works. You can see the second slide, please.
Yes, Professor,
Someone
we
can
can.
say me if everything works. You see the second slide?
Yes.
Okay. Today we talk about the tumor markers. What means tumor markers? Tumor markers are molecule. We talk about the tumor markers as molecule present in the blood. And how we can monitor these kind of molecules. Tumor markers are any kind of molecules present produced directly from tumor or from our organism in response to tumor. Which kind of tumor marker we have and how we can use it? We can have marker for screening tumor. What means screening tumors? When we don't have any kind of evidence, but we can monitor and verify and predict if one people could develop tumor. We have also markers to detect very early the presence of cancer before any other instruments. We have marker to make diagnosis. Generally, the marker present in serum or in blood are not for diagnosis. They can help to make the right diagnosis, but they itself are not enough. We have marker to staging a cancer and verify is poor, aggressive, or not. We can use marker to determining the right prognosis of a certain kind of cancer, the efficacy of treatment that we are using. We can monitor the presence of recurrence, assess response to specific treatment, and also marker for follow-up the patients. We can imagine to have the ideal marker. The ideal marker is a molecule very high specificity. This means that is present only when the patient have a tumor and is completely absent in healthy patients. So, or not related for tumors. We can imagine to have a marker very sensitive, able to detect the presence of tumor when he is very small, or predict if there is good prognosis or not. We can have marker specific for one organ, and the opportunity to have a correlation between this marker and tumor mass and prognosis. But now, so far, we don't have this kind of marker. We have marker that satisfy one or two or at least 3 points, no more than this. Generally, we can, as I told before, we can imagine to have molecules absent in healthy patient and present in presence of tumor or tumor patients. But generally, we are in this gray zone. In this gray zone in which patient healthy also have this marker, and also patients with tumor that haven't these markers or these molecules. And in this gray zone, we need to work better, and we need to have more than one markers to monitor and to detect the presence of tumor. How we interpret our tumor marker? First of all, as I told before, we don't have marker from blood, are not diagnostic. Generally, the marker present in blood help to make a diagnosis, but we need other instruments such as CT scan and many other technology, biopsy, and so on to identify the presence of a tumor in the blood, in the body. Another important point is the marker is released in the blood in dynamic change. This dynamic change is related to grade of disease, is related if the patient is already performed a specific treatment or not. Is related sometimes on tumor mass. Generally, with the marker present in the blood, we can monitor a very small tumor. Also, when we have a small number of cells compared to clinical diagnosis, all clinical aspects of features of our patients. So it's very important examination of patients, and also repeat more than one time the analysis, the blood analysis, and monitor more than one time the presence of one or more than one tumor markers. We can use also tumor marker to follow up the patients. When we start the treatment, we have to monitor if the treatment is working or not, and also if there is efficacy of our treatment, and change the treatment if it doesn't work. From biochemical characteristics of marker, we can categorize the molecule in tumor antigens. That means glycoproteins present on tumor surface or produced by an organ specific after the development of tumor. We have also enzymes. We have hormone that can be used as a marker. We have, of course, oncogene and many others. We talk at the end of our lesson about the presence of immunoglobulin, and also about the presence of specific antigen as PD-L1. Probably someone told you about PD-L1, about regarding to treatment of lung cancer. Someone can answer me? Nobody answer. Okay. What means
haven't reviewed the lung cancer yet? So
yeah, you someone told you about the PD-L1 therapy?
Not yet.
Not yet. Okay. PD-L1 is antigen present on tumor cells, also in immunity cells present in tumor mass. in the tumor microenvironment, and is a good marker to treat patients. So then we talk later. About the PCA. PCA is the only marker that we have, very sensitive, and that we can use also for screening patients, together with other kind of marker associated with hereditary tumor, such as BRCA1 and BRCA2. Probably someone told you about these two genes that are predictive of development of breast cancer. PCA is the only marker, very sensitive, very specific, that we can use for prostate cancer. Another marker very useful and very sensitive is alpha-fetoprotein, and is very important to screen hepatic carcinoma. Okay. Now we talk about the main characteristic of individual marker, how we can monitor and how we can use. Alpha-fetoprotein is originally a fetal protein, not present in normal tissue, in normal healthy tissue, and during the life. It's only present in fetal life. We can monitor in blood. We can take a little bit of blood from patient using a tube test with the top in color red, and on this blood we can monitor the presence of alpha-fetoprotein. Here there is the half-life. The half-life for us is very important. For us, also for you, is very important, because we need to know how resistant is this marker, especially when we are treating a patient. If we want use to monitor disease, and the patient is already treated with a specific drug, we need to know how long is resistant these molecules. If the patient is treated and we monitor too early the presence of alpha-fetoprotein, probably we are not able to monitor alteration, because it is already present. We have to wait at least 4 or 5 or 6 days before to monitor again and verify if the treatment is working. Alpha-fetoprotein is present at high level. That means 10-fold higher than normal range in 80% of carcinoma from hepatocellular carcinoma. That means that 20% of patients that doesn't release alpha-fetoproteins. So for this kind of patient, they are negative for this marker, but they already can have disease, tumor disease. This marker is non-specific because also ovarian cancer can express alpha-fetoprotein, and also other kind of tumors such as colorectal carcinoma or lung cancer. But the take-home message is alpha-fetoprotein is a good marker to monitor or to make a better diagnosis or help diagnosis of hepatocarcinoma. Another marker is PCA. As I told before, is a very sensitive marker. Is specific for prostate cancer, but is also present in benign condition. So when we have infection of prostate, we have already an increase of PSA. How is this marker, when he's at least 8 nanogram per ml, is a good indication that is a tumor and is not infection from prostate. This is I also show you the half-life of this marker. Is very important because we can monitor the treatment. If we assess that, if we have already made diagnosis of prostate cancer and the patient is treated for a specific drug, we have to monitor the dynamic changement of PCI marker, and we have to wait. We have to wait 2 or 3 days after the start of treatment and monitor again the presence or changement about the PCA to verify if the patient are responding or not to treatment. PCA, of course, is not the only marker that we use. Sometimes we use other instruments to make the right diagnosis. But PSA is very, very sensitive and is elevated. Also, weeks before that, we can monitor with rectal examination of prostate. Is high sensitive, and we use to follow patients and also to assess the response to therapy. Another marker is CA. CEA is a glycoprotein, also present in blood. We can take anyway another small amount of blood and verify the presence of these proteins. Also, this protein is an embryonic antigen. It's not present in a normal adult individual. This is important notice is the important news is that this marker is increased in a smoker is 2 times more than the normal range in smokers individual. So when we want assess, we have asked to patient if he's a smoker or not. On base of our information, we can analyze the data from a laboratory, because if is a little bit higher, we have to ask if the patient is a smoker or not. CA is not specific, but is increased in colorectal carcinoma, at least in 80% of patients affected by colorectal carcinoma, but is present also in breast cancer. That means that CA antigen can help the diagnosis of colorectal cancer or breast cancer, but it isn't an early marker of disease and is not specific. It's a broad range of marker, and we can use this marker to help the diagnosis.
I have a question.
Yeah.
Regarding the CEA, why is it higher in smokers? What is the reason behind it?
Because it's inflammatory situation. And the inflammatory situation induce changement in normal tissue. So this changement determine that the cell start to produce something that was originally in the embryo stage. Also for PCA, when we have infection, we have inflammatory situation. Sometimes the cells start to produce something that was originally switched off during the development. This means that our epigenome, I don't know if you know the words, epigenetic, you know?
Yes.
Yeah, epigenetic is a changement in chromatin of DNA sensitive to microenvironment. When we have infection or when we have inflammatory, the microenvironment inside the microenvironment can influence the genome via epigenetic modification and start to produce something that was in the embryonic stage. When the environment is very toxic, we have a large changement, and we have a lot of pathway that was originally present in embryo, right? CA we can use also to monitor the disease. Before surgery, we can observe this increase of CEA associated with the poor prognosis. When after the surgery, we can ask to monitor again CA, for example, for colon carcinoma, and to monitor if is already increased. That means that is already present some tumor cells or the tumor is spread away. So we can expect the presence of metastasis that we cannot see with the CT or other instrument. We can wait at least 3 or 4 months before to see the metastasis by CT scan or PET MRI or other technology. We can use this marker after surgery, just to monitor the presence of early metastasis or before that was visible with the CT scan or other technology. CA125 is a very good marker for ovarian cancer, epithelial ovarian cancer, because it is expressed at least in 19% of patients. And this is half-life, as I told before, is important to follow and remember the half-life, because we monitor this marker, the dynamic changement of this marker during the treatment of patients. Is not specific. It's not specific because it's present also in 40% of patients with other kind of ovarian cancer, but also in lung cancer. It's not specific, but could help for diagnosis and could help for monitor the response to treatment. CA is a glycoprotein released in the blood from tumor cells because is the fetal origin of this antigen, is not expressed in healthy patient and is not expressed during the adult life. The 19% means that the 10% of patients are negative to this marker, but they have also ovarian cancer. So again, we have to ask for this marker when we suspect ovarian cancer, but if the marker is negative, that means that patient haven't cancer. We are in gray zone, and we have to wait some days, repeat and repeat, and sometimes ask more than one marker for the same patients before to decide the treatment and make the right diagnosis. CA125 is used before and also to follow treatment, and higher level, 10 times more than normal range, indicate a poor prognosis, high grade of disease. And sometimes also indicate that the women are not be treated with surgery. Okay. CA15 is a glycoprotein, again released in serum, is associated with breast cancer. We can ask when we suspect breast cancer, when we suspect breast cancer, but it's not the only one marker for breast cancer. We are also myokinin-1 and cytokeratin 19 that we ask together. At the end of lesson, I will give you information for each disease, for each kind of tumor, which marker you have to ask together. This indicate, of course, again, the half-life of marker. CA15 is also present in benign condition, also when we have hepatitis. The problem is again the same. When we have cellular alteration due to infection, due to inflammatory situation, cells try to produce something that was original present during the early life, during the fetal life. So it's not a good marker to make diagnosis, help diagnosis, but it's not diagnostic marker because also benign condition is present CA18. So is very sensitive marker and is present in all stages of breast cancer. So we can use to monitor the disease and treatment. CA19 is a marker, but is a marker of tumor cells. So these markers indicate that tumor cells are present in the body, and when we monitor CA19 in the blood, means that tumor cells are spreading away, are released in the blood, because this marker is a marker of tumor cells. So is present in malignancy, is not specific because it's present also in pancreatic cancer, in colon cancer, in biliary tract cancer, but also is present in benign condition. We can use this marker only to help diagnosis, not to predict, not for diagnostic a disease. Just to use, we use CA19 marker in malignant situation. in 70% of pancreatic cancer is a good percentage of patients. So if we want to make a diagnosis, or if we want to follow the patient during the follow-up or during the treatment, we can monitor this marker in pancreatic cancer. But also remember, is also present in benign condition, and we cannot use it to diagnostic. Yes. Again, is elevated, particularly elevated when the lesion is very big, and sometimes is associated with this disease. The tumor is spreading away, because, as I told before, is a marker of tumor cells. So when we monitor the presence of this marker in blood, means that tumor cells are in blood. Probably everybody knows this marker is a pregnancy marker, but is hormones. When we observe this marker, when we have ovarian cancer, when is a germ cell tumor of ovarian cancer, also for testicular cancer, we have to exclude that patient is pregnant. But when this marker is present, we have a good indication if this man is a testicular cancer, yeah, or a certain type of ovarian cancer. Calcitonin is an hormone. Normally, is produced by thyroid glands. When in the blood we have a higher than normal value of calcitonin, means that, or is a good indication that we have alteration in thyroid glands, and we have to verify with other instruments is a tumor or benign condition, hyperplasia, or so on. Is particularly elevated in medullary thyroid carcinoma, but also in lung cancer. As I told before, can be elevated also in benign condition such as noodle. Only biopsy, fine needle aspiration, and analysis of biopsy with the immunohistochemistry can give you the best indication how to treat these patients. Sometimes surgery, sometimes not, sometimes they need chemotherapy and other kind of thing. But the decision make depends, first of all, the presence of calcitonin and thyroid tumor, the thyroid markers, and monitor the level in the blood, and then also biopsy to make the right decision and to make the right diagnosis. Beta 2 microglobulin is an immunoglobulin. This immunoglobulin is very high when we have leukemia. Is a good indication of leukemia. Is not diagnostic, of course, but we can use this marker to follow disease and also if treatment is working or not. It's more easy to take a little bit of blood and monitor in blood than other type of diagnostic system. Is easy and also is very quick. Is not specific also because also renal disease can indicate the increase of beta 2 macroglobulin. A patient with the higher, at least 10 times or 100 more normal range indicate a poor prognosis. So higher level is indication for prognosis of this disease, for example, for leukemia. BTA is another marker used is very sensitive, used to help the diagnosis of bladder cancer. Sometimes is used to stratify the patients to determine the grade of disease. Is very sensitive, but is only present in 50-60% of present. We can monitor in urine. We don't need blood, and the examination is by ELISA. Probably everybody knows is a system to monitor with specific antibody the presence of protein. It's very important to check which kind of technology is used to monitor. Sometimes the laboratory give you information not only about the marker, but also about the technique used to monitor the marker. If they monitor in urine or if they are monitoring blood, if they use direct monitor the protein with antibody, or they are looking for antibody against the antigen. Of course, if the laboratory are looking for proteins and check by ELISA is more sensitive. If the laboratory are looking for antibody against antigen, tumor antigen, is less sensitive because they are looking for antibody release from the body, follow the exposure to antigen. So it's less sensitive. You have to ask always to monitor directly the protein by ELISA system. If you don't see on report from laboratory, you have to ask to have a better system to monitor the marker, right? Also, lactate dehydrogenase is not specific marker, but can help to follow non-small lung cancer disease and also to monitor relapse disease. I can show you how to monitor in a flow chart. Also, we have chromagreen. They are enzyme. We monitor again in serum. It's not specific, also because we have different kind of tumor. What is important in our diagnostic process? As I told before, the tumor markers are not used for diagnosis, but can help to determine the presence of cancer and help to make the right diagnosis. Sometimes can help when we have a spread cancer, when we have metastasis and we don't know which is the primary site of a tumor. On the basis of a marker that we use, we can choose which is the primary tumor. We can ask for several tumor markers. Kind of primary tumor could be. Of course, some markers are better, such as high level of CA125 strongly suggest ovarian cancer. Again, also, as I told you before, some markers are not very specific, but can help. How? For example, for testicular cancer, if we ask if we ask alpha fetoprotein, beta HCG, and also LDH, all together, we can stratify the patients, and we can also have an indication about the stage of tumor. We can use a serial or marker. For example, here I indicate we can use mucin 1, Ki67, here HER2 for breast cancer. This marker all together can give us a good indication about the prognosis of patients. 125 is a good indication, as I told before, for ovarian cancer, serum level. Also, a combination, for example, of ER, PR hormones is a good indication for breast cancer. We told later about how we can use presence of receptor, estrogen and progesterone receptor, to stratify breast cancer patients, and how to use this kind of marker to make the right decision about the treatment of patients. We have also marker for recurrent cancer. One is 125, is a good indication of recurrent disease for ovarian cancer. CA is a good indication for colorectal cancer. 100 CA 15 is a good indication for recurrent of breast cancer. So they can help. This marker, the blood marker, can help to make the right diagnosis and follow dynamically the patient and treatment, and follow up the patient. How to use receptor? We can use a specific hormone receptor, not as a marker of treatment. Generally, this marker can be useful to stratify the risk of patients and are predictor of prognosis, if they survive or not, and also which kind of therapy is most likely for this kind of patients. Generally, estrogen receptor, progesterone receptor for breast carcinoma can monitor directly by immunohistochemistry on biopsy from patients. Also, from that biopsy, we can prepare proteins and monitor the amount, but the amount of estrogen receptor is monitored directly in biopsy from patient, not in blood. Is not sensitive. Monitor the amount of estrogen receptor in blood. The best way is take a little bit of tissue and analyzed by immunohistochemistry, and the pathologists are able to give you information how is the score of positivity to this receptor. On base of score, they give you if how many cells are positive or negative to this receptor. Generally, we use this kind of score. If the percentage of cell positive to receptor are lower than 10%, the tumor is negative to estrogen or progesterone receptor, and we told later is a poor prognosis. If the patient is positive to ER or progesterone receptor, generally they need to have 60% of cell positive. Is very high positive, is a good prognosis, and this patient benefit of hormone therapy. They are good responder to this kind of therapy. Of course, the degree, I remember you, is performed by immunohistochemistry from biopsy, not in blood. Blood is not a good indication. Also, for URB is expressed in breast cancer. Anyway, is predictor of prognosis. The patients that are positive to this receptor can be benefit for treatment with antibody against this receptor. They, if they have they overexpress, are positive to this receptor, they can treat it with this with the specific immuno drug, is antibody able to block the signal transduction of this receptor and at least reduce the tumor mass, and then the patient can be treated with surgery. RB is present in breast cancer, but also in ovarian cancer. So when we have suspect of breast cancer or ovarian cancer, we have asked for breast cancer also for estrogen, progesterone hormone, and also for RB to make the right decision about the treatment of patients. Is epidermal growth factor is again a receptor for growth factor. Non-small lung cancer, head neck cancer, also pancreatic cancer can express this receptor constitutively. This means that this receptor is always activated, and the cells grow very fast. We can use this receptor to monitor if we can treat these patients. So this receptor is useful to stratify the patient on the base of treatment that we can use. It's a system to personalize treatment. Again, I can jump this, is only to indicate PCA for prostate cancer, breast cancer, which kind of marker we can use, and how can we monitor. For melanoma, we have to ask tyrosinase, immunohistochemistry for S100B, and MEA for melanoma. How to use this marker? Tyrosinase is a marker that we can monitor by RT-PCR in the blood. But when the patient is positive to this enzyme, this means that melanoma is spreading away, because we monitor cells in blood. This means that melanoma is very aggressive, and probably in a few months we will observe metastasis. Also, S100B is a marker to analyze metastasis from melanoma. It's very aggressive, and on the basis of this marker we can decide which kind of treatment. Before surgery also we can ask this kind of marker, because if we have also marker of spreading very aggressive tumor, when we have to perform surgery, we have to increase the margin of resection, to have a big resection, to able to eliminate a very large amount of tumor mass. For thyroid cancer, as we told before, of course we ask for a specific thyroid tumor that are expressed at higher level when we observe tumor, but it's not enough. Of course, we have to perform biopsy and analyze exactly the histology of tumor with specific marker. Also for squamous cell carcinoma antigen is very important for prognosis and staging. This slide is to recapitulate which kind of marker we can use and how we can use. Most of them, you see, are not for diagnosis, are not for screening. They can help, and here is indicated which kind of tumor can be useful, this kind of marker. Only marker that we can use for screening, marker in blood, of course, is PCA. We can predict if these patients could have a cancer, but many other are not for screening, also to help diagnosis, also to help us to monitor the therapy. So we need to use for dynamic monitor the disease. For colorectal cancer, the best marker that we can use take blood is CEA, is useful for colon cancer. For example, this just a case, a male, 63 years old, with the presence, with nicturia frequently. With the rectal examination reveal a large nodular sorry, was someone called me during the lesson. So, which is the right decision on the base of this case? Which kind of marker we can use? Alpha fetoprotein, alkaline phosphatase, PCA, CA, CA125. Of course, if we have a male and after rectal examination, we can ask to have PCA and also ask to have a biopsy to monitor again with the specific marker. This is glycols. I don't know if someone knows. Is a marker used in histology to monitor the presence of urinary prostate cancer. This is another case. Sorry, I jumped. Is another case. Is just to monitor, for example, women with the abdominal pain. Which kind of marker we can use? Of course, we cannot use PCA for a woman. She has abdominal pain. We have to examine the pelvic and which is the marker that we can use. Of course, sorry. CA125 because we suspect, for example, ovarian cancer or something like that. And then by histology, we need to verify if there is a benign condition or cancer. Only histology can give you the right information. These examples also only to see you that is easy monitor with marker in blood, but they are only indication. Most of them I need to make the right diagnosis more help, such as biopsy or other instruments to monitor the presence of cancer. Probably everybody know about the oncogene involved in tumor development. I don't want to talk about the oncogene, of course, but how we can monitor these markers and when we observe these markers in blood. When we observe this marker in blood, this means that tumor cells are released in the blood. This means that tumor is very aggressive. This means that the tumor is spreading away. So when we ask this marker in blood, this means that the tumor is very aggressive. There are few cases that we can ask oncogene and is not related to very aggressive tumor, and then we talk later. Of course, KRAS is common and mutation are present in colon cancer. This kind of mutation can be monitored by RT-PCR or by direct sequence. This kind of tumor is not for diagnosis because probably the tumor is already diagnostic, but it's important to make the right decision about the therapy, because we have therapy for colon cancer that have KRAS mutation. So this marker is useful to decide the right therapy for this kind of tumor. Generally, molecular biology technology is important to personalize the treatment of patients. Also, P53 is a very common mutation associated with a lot of tumor. P53 is important to monitor by immunohistochemistry because give you more information about the stage of tumor. Is very aggressive or not? Of course, P53 is not diagnostic because it's always increase in tumor. We have to ask histology and mutation, looking for a mutant state of P53 or aberrant alteration, duplication, genetic alteration of P53. When we monitor in blood, this again means that the tumor is spreading away. So if we monitor P53 in histology, this marker indicates you that the tumor is very aggressive, is proliferate very high, because P53 is a guardian of DNA replication. If the tumor has a very high level of P53, means there is muted or there is a constitutive activation. This tumor is very quickly growth rate. Again, for Ewing sarcoma and for leukemia, we have a lot of chromosomal derangement. For Ewing sarcoma is a bone tumor, is for children, high incidence in very young population. So haven't specific liquids markers. So when we have suspect that a tumor is present in bone, we have to ask genetic information to write the best diagnosis. This rearrangement present in Ewing sarcoma is diagnostic, because is peculiar of this kind of tumor. For example, we have this kind of rearrangement in rhabdomyosarcoma is again a bone tumor. In ataxia and also for renal carcinoma, we have a specific rearrangement. So this marker helps the diagnosis, but this marker can be monitored in directly in biopsy, or we observe this marker in circulating tumor cells. So we observe in blood cell with this rearrangement when the tumor is spreading away. So also for thyroid cancer, we can ask to verify the presence of proto-oncogene rearrangement or constitutive activation in biopsy. They can prepare DNA and analyze biopsy. Another kind of tumor, we have also some kind of tumor that have hereditary disease. One of most rearrangement mutation is BRCA1, BRCA2. is very interesting, this kind of marker, because it's a screening marker. It's a screening marker because we can observe this mutation before the development of tumor. For breast and ovarian cancer, we can observe this mutation, this hereditary mutation, so we can monitor in blood. We can ask if we observe history family of tumor, we can ask to take a little bit of blood and verify in blood specific mutation associated with tumor. Is in family history there is breast cancer tumor, we can ask for BRCA1, BRCA2, and if we observe mutation by RT-PCR and direct sequence, the guidelines indicate that the patient can be surgery before tumor develop disease. So this mutation on the basis of guidelines can give to patient the opportunity to have surgery before the tumor can develop. In this sense, this kind of marker are useful to screen the population. So another important marker is epigenetic marker, is for hepatic carcinoma. Is in some hereditary form is associated with specific mutation in endoglin. So we can looking for regulative element mutation, and the guideline indicate that we can give to patient the opportunity to choose surgery before the tumor can develop. This is for BRCA1, BRCA2. This agarose gel. Here are the band that indicate the mutation. It is an extra band. This indicates that patient have mutation in BRCA1 and BRCA2 gene. Another history about the breast cancer. I can show you how we can stratify the patient on the basis of risk and which kind of treatment we can offer for this patient. This patient can be breast cancer, can be stratified on base of estrogen and progesterone expression. Of course, they are receptor. We can monitor the presence of this marker on the basis of biopsy. After biopsy examination, we can have results, and we have an indication if the patient is positive on the basis of numbers of cells positive to this marker. So in the category of luminal A, we indicate the patients that are RMPR positive, estrogen and progesterone positive. In 50% of patients, this breast cancer is invasive. Sometimes they are negative to new, and then we talk about the biological feature of this in the next slide. In luminal B, these patients are associated with low positivity to RMPR receptor. Sometimes they are positive to new, so we can offer this kind of therapy. Then we have patients that express high level of HER2 receptor. So these patients are negative to estrogen and progesterone, and this kind of tumor is high proliferative, so they are very high P53 positive, they are Ki67 positive, they have a high rate of proliferation. So we have also another degree for breast cancer called basal-like tumor. This kind of tumor is negative for estrogen and progesterone, and also is negative for HER2. They call triple negative breast cancer. This tumor is very aggressive. The patient with the triple negative breast cancer have high rate of proliferation. Which kind of treatment we can offer to this patient? Breast cancer offer several opportunities, is higher investigated. So the stratification of a patient on the basis of the marker that I show you help to make the right decision about the treatment, how to monitor the patients. Of course, the patients positive to estrogen and progesterone hormone have the good prognosis. They are treated with hormone therapy. They are good responder, but we have to follow the disease with using CA15 or mucin-1 in blood, but also with CT and other instruments. Luminal B is higher grade than luminal A. They respond anyway to tamoxifen treatment and aromatase inhibitor. They are generally good responders. Then we have HER2. They have also P53 mutation. So they have all these patients have also positive nodule. They are high grade. They respond to antibody treatment against HER2 receptor. So the indication for these patients is this antibody. They respond anyway to chemotherapy. In the other case, in the other kind of patient, they don't need chemotherapy. These patients have a poor prognosis. In triple negative patients, they have, of course, mutation of P53. They have higher growth rate. They are BRCA1 dysfunction. Sometimes are also mutation, familiary mutation. They are not respond to standard chemotherapy. We can offer chemotherapy based on platinum. They no respond to immunotherapy, neither to estrogen and progesterone, neither to trastuzumab, and they have a poor prognosis. So in these patients, we have to monitor the metastasis, the development of metastasis, and eventually the response to therapy. Also for colorectal cancer, we have opportunity to monitor if we have observed family history, have the opportunity to follow these two genes. these two genes give us the opportunity to make the diagnosis before the tumor develop, so we can offer the patient a surgery before the tumor give the first evidence. Also for hepatic carcinoma, we can observe the alterations, microsatellite. Of course, also for leukemia is the most common molecular biology examination. But also, as I told before, initially, the first evidence in blood is the presence of beta 2 microglobulin, is an immunoglobulin that give you information that the patients are developing lymphoma or leukemia. Of course, genetic analysis is for diagnosis of leukemia. Most common are gene rearrangement. This is only a scheme to show you how to monitor an extra band due to most common rearrangement. How to monitor? We need to take blood from patients and analyzed by RT-PCR, looking for extra band on chromosome. For leukemia, the presence of extra band is diagnostic of leukemia, together with fluorescent cell sorting that give you a large increase of lymphocyte population. The take-home message: we can never use one marker, but more than one. Also, we can load on gel the lymphocytes and verify an extra band, monoclonal or polyclonal lymphocyte population. Most of hematological tumors have peculiar chromosome rearrangement, is indicated here the breakpoints and rearrangement that involve 14, 18 chromosomes for large cell lymphoma. And these cells, what happened? We have an increase of BCL2, is anti-apoptotic gene. So the cells grow continuously, they survive, they don't block, they grow. So we can observe a higher level of lymphocytes because they grow in uncontrolled, without control. Also, other rearrangement, probably you will see in hematology in more specific or genetic. My take message in tumor marker: we are everyday novel marker, not only for we are looking every day for novel marker to early diagnosis, because everybody knows the best way to win the cancer is the prevention. Obtain the very early diagnosis. We can the novel marker are genetic marker or epigenetic marker. Epigenetic marker are modification induced by environment. For example, novel markers are for liver carcinoma. We have modification in two genes, P15 and P16. The environment, the tumor microenvironment, can silence the regulative element of this gene. So These genes are involved in cell cycle regulation, probably everybody knows. So they switch on. So this cell can grow abnormally. This does mean that they necessarily develop in cancer, but this is very early events, and if we are able to monitor this alteration, this modification, we can have a prognosis before we can also have a screening test to monitor which kind of patients have could develop tumor in the future. And now our goal is have screening test to monitor before clinical evidence to monitor patients. We have also genetic as nuclear, everybody KRAS for example, but also novel markers are from mitochondria. Mitochondria probably in genetic you have already studied. We can prepare DNA from mitochondria and monitor several kind of gene. Recently for bladder carcinoma, we have alteration of ND4 gene. This mutation in this gene expressed in mitochondria is a good indication for screening bladder carcinoma. Which is this slide indicate the diagnostic pathway for lung cancer. For example, when we have suspect about the lung cancer, we need to test EGFR mutation. It's important because we can use this marker to treat patients if there is a mutation or is wild type. We have now antibody against EGFR mutation or for wild type. If we observe mutation, we have better treat these patients with tyrosine kinase inhibitor. They respond. Now we have more than one TK inhibitor on the base of mutation that we can analyze on first step on histology, histology analysis of biopsy. Then from a small amount of cells we can prepare DNA and then verify which kind of mutation have, because we don't have antibody for a single mutation. So in the first instances, we monitor mutation. Then we can try to identify which kind of mutation we have. On the basis of mutation, we can choose the right tyrosine kinase inhibitor, generate small molecules, well tolerated, very low adverse effects. So we can treat these patients. If we don't have a mutation in AGCR, we also looking for other marker less specific, that give you other pathway constitutive activated that we can block with specific marker. So the second message is, first of all, for lung cancer, we don't have early marker, good indicator or marker before the clinical evidence. So often the patients have already the disease when is diagnosticated lung cancer. This means that the patients have already developed the disease. The first of all is blood examination that for general marker, because there is no specific blood marker for lung cancer. Then you have to ask to biopsy to monitor which kind of marker is effective. Sometimes we can take from saliva or from blood cells, and looking for mutation, for a GSR mutation. But that means that the lung is already aggressive and already release tumor cell directly in blood, in circulating blood. Which is the next goal. Just briefly give you information about this immunotherapy. This immunotherapy is very recently and very powerful therapy, because immunotherapy give less adverse effect, is less toxic than chemotherapy. So oncology looking for activation of a specific receptor present on cells and choose immunotherapy for treat patients, because they have lower effect, lower adverse effect, and less toxic than the other. This means that patient can come to hospital only the day of treatment and go away, and it's more easy also to treat patients. PD-L1 is a receptor. We are treating now lung cancer, melanoma cancer, kidney cancer. This is a receptor, is an immunoreceptor that the tumor cell express to escape, to evade from immunoregulative system. So the tumor cells say to body, don't eat me because I am self. And in this way, the tumor express PD-1. The therapy is against this receptor, to cover this receptor. In this way, the body recognize as non-self again the tumor cells and can eat the tumor. So this is a very novel therapy, currently in a very advanced stage, and is helpful therapy to treat lung cancer and melanoma. Now we have a lot of drug that to better treat using this pathway, or to improve this pathway to obtain the best treatment with the less adverse effects. But probably oncologists give you more information about this therapy. Which is the take-home message of this lesson. And we have finished. We have only PSA at the moment as screening marker before any clinical evidence, but it's not diagnostic, depends on the level. If the level is at least 8 nanogram per ml of PSA, we can for sure say the patient have a tumor. We have generally marker for staging, prognosis, and follow-up. we have different kind of marker on the base of tumor. If we have an indication that the patient have a breast cancer, we have to ask this marker and verify if they are positive or not. For ovarian cancer, we have these kind of markers all together and use all of them to make the right decision. We have also marker for prognosis again, for prostate cancer, for pancreas cancer, for different endocrine tumor. Again, remember the following points. When you order in laboratory serum marker, never rely on a single test, never. Recommend a panel of markers because remember, often we are in a gray zone. We are patients that cannot express the marker for different kind of situation, other therapy or other kind of disease. It's very important. Use always the same lab with the same assay. Verify the kind of assay. If they are looking for direct proteins or they are looking for antibody against the proteins, because it's less sensitive looking for antibody against the proteins. Consider always the half-life of marker when you use them to following the therapy, and take in mind that marker change dynamically. Consider also the metabolism of the people. Sometimes the metabolism change on the base of treatment, on the base of the age, and several others disease. In the future, we try the molecular marker are looking for a diagnostic, but also marker to choose the right therapy for a single patient. We have now different technology on the base of marker validation, analysis of all collecting all data from omics data, genomics, proteomics, epigenetic data, all of them. But we need always clinical examination of the patients. We have to fit always all this data with the clinical examination, with the clinical history of the patients. So we are looking for a marker for personalize the therapy, for personalize the treatment, and follow individually the patients, at least for cancer. Thank you to everybody to hear for 2 hours more or less, and I hope everybody are enjoyed. If there is question, or we will see tomorrow.
Thank you very much, Professor.
Thank you, Professor.
Okay. Yeah?
No, I said thank you.
Yeah, okay. We will see tomorrow. If you have a question, you can ask, or you can think, or you can recheck the slides. If you want some elucidating about the tumors, you can ask me also tomorrow, because we will see. We will not see, but we can hear tomorrow. Okay? Thank you very much for your attention, and okay, we will see tomorrow. Bye. Have a good nice day.
Thank you. Thank you.